So, good morning. Thank you for having me. I'm also, what's important on my bio that might not be there is I am a fellow, so please note that. So, let me tell you that this was about a 3-year birthing process, and my colleague in the room, Bonnie Ewald, and I were co-conspirators. We had essentially, I'm giving you one backdrop on this because it's critical to know. When I saw the Future of Nursing report come out about 10 years ago now, I think, because they're doing the 10th one. About 5 years ago, I was thinking, how do we possibly create a Future of Social Work report? And basically, we gathered, I talked to people on the Future of Nursing report, the chair, Stuart Altman, at the time, and he said, you do everything by building a coalition first. And we got together all of the big leagues, most of the big schools of social work deans, every professional association related to social work, in a room on the phone every month, maybe more than every month, for about a year or so, and at the same time, the National Academy invited me to come speak on an aging-related subject, and I did. And I knocked around the idea of, with this person I was speaking to, I said, you know, we have this idea about a social work report, and she said, my mother's a social worker. So it's all about who you know and how you know them, and we were absolutely able to craft a statement of task that we ultimately ended up broadening to much more of an interprofessional one. And this is, we were able to change the title, which was a very long title before, it's still a long title, to Integrating Social Care into the Delivery of Health Care, Moving Upstream to Improve the Nation's Health. Has anyone been on a National Academies panel, consensus panel, for the year, for 2 years? So it's, you can talk about it maybe at the, when we have Q&A, but it is really an unusual process, and I hear one experience is just one experience. And here I have the whole printout. The final copies will be out in a 2-month period, but I'll let you see that. And today I probably won't go into some of the great examples that are discussed there, but you can peruse through. Committee members were real national leaders in social care, social determinants, and the chair was Kristen Bibbins Domingo. Do people know her from UCSF? Very much a public health type physician. So the committee had one nurse who was upset she was just one nurse, Liz, on there, which I don't blame her. 3 social workers, which we were upset there were only 3 social workers, and tons of physicians. So you can imagine some of the fun we had. And really the statement of task was pretty clear: to look at healthcare providers and systems and new emerging approaches related to social care, and trying essentially to concretize what are the issues in delivering, why social care, even though some of us know it, not everyone does know it. It's very much a level-setting report in many ways. And we had to keep holding on to that there were experts in the room, but we had to also speak to people who hadn't grappled with this notion that our health outcomes aren't the best in this country, and probably a big part of that reason is we don't invest a whole lot in social care. So that was a premise or a hypothesis for us. So you can see some of the committee members there. Maybe you know some of them. Quite a brilliant group of people. If you've never seen the Siren website out of UCSF, something for you to check if you're going into the social determinant realm. Very unbelievable group. Siren stands for, help me.
Social Intervention, Research and Evaluation.
Yeah, very impressive. So thank you, Bon. So our approach was to collect information, review the evidence, develop findings and recommendations, summarize that evidence, and conduct an external review of the draft report, which is really a hefty process. And most of us really were part of the writing. So we needed someone to synthesize all the different authors, of course. And we very much, it had a lot to do with social factors that we talked about most in terms of housing, food, transportation, all influence health, that we're traditionally not speaking about those in healthcare systems. And what I said, if you attend to social factors, the belief that we'll have greater high-quality, high-value healthcare. And being in a value-based, moving toward a value-based healthcare system, we felt like this was a perfect time for this report to come out. And there's a growing body of evidence. No one knows exactly what to do when, but we definitely gave guidance in this report. And we really created a new taxonomy, if you will, that I'll talk to, or a framework to organize the discussion about these activities. Feel free, because of all the brains in the room, to interrupt me anytime so we can dialogue about it too. So we know we wanted to also put a frame around health equity. Everyone's talking about health equity. Not everyone, but we all should be. And I think we all pretty much know what it is, but we wanted to talk about this framework, and this report is part of the health equity strategy that we're developing, hopefully across the country, across the world, and trying to reduce, of course, the disparities in health, and trying to show how the social needs influence that. Part of how we changed the name of the report, which is important, let me say, integrating social care, but that moving upstream we thought was critical. And we can talk about that later, because it may mean different things to different people. Some of the, we developed a it's important to know that it's not a one-size-fits-all approach, and that there really are 5 activities related to making all this happen. There's ones focused on individual adjustment and assistance, and ones focused on the community's alignment and advocacy. And awareness is really the middle box, because you can't do anything until there's awareness of who might be struggling, who has problems. So if we look at this, if we break it down and as an example of transportation, and I know a lot of you are thinking about transportation as one of those social determinant issues, awareness in that case would be identifying the social risks and assets defined by patients and populations. So basically, the awareness piece would be simply asking people about their access to transportation. Pretty basic, right? The adjustment activity would be focusing on altering clinical care to accommodate identified social barriers. So this might be helping a person, help them through telehealth appointments, or in other ways, going to them rather than them needing to come to us. Assistance has to do with activities that reduce social risks by providing assistance in connecting patients with relevant social care resources. So this would be things like we are doing at Rush. We have a relationship with Kaizen at this point, where we give vouchers to patients to help them get to healthcare appointments, or help them get home after they've been in the hospital. And they can be used for, ride-sharing services and or public transportation vouchers as well. So that's something that we're seeing utilized more and more, and I know we've talked to Blue Cross about that too. Alignment are activities undertaken by the system to understand existing social care assets in the community, organize them to facilitate synergies, and invest in and deploy them in to positively affect outcomes. And this, I think, is something that you're talking about. It would be investing in a community-wide ride-sharing program to address, or a time bank, or something more across our various systems to create an economy of scale. And then advocacy, of course, has to do with advocacy, both within organizations to promote policies that facilitate the creation and redeployment of assets and resources. And this has a governmental touch too, to work to promote policies that fundamentally change the transportation infrastructure within the community. So that is happening some in Chicagoland, not enough probably, but some. So this seems to be, when we do our social determinant screen at Rush, it's amazing, transportation comes out as the largest need. I don't think anyone's surprised by that, right?
Can I ask a question?
Of course, Candace.
Yeah, okay, so obviously that transportation issue is logical, and then if you're asking about it and people need that, from execution, who's paying for that? I'm more curious, because that's just, then it gets like, well, you pay for it, you know what I mean?
Absolutely. I think every system's a little different. payers are figuring out that if they invest in that and pay for it, then downstream costs will be less. So, upstream, whatever. Costs will be less later on. And so at Rush, each department has money set aside based on what they think it will take, and they pay for it. Of course, we evaluate first whether or not someone can pay for it themselves, but those are not necessarily the people we're seeing. So we do end up paying for it. And we are trying to really look at the return on investment in that to see if that is, if it's sustainable or we could grow it. So, it's complicated.
Yeah.
Any other response to Candace, how anyone else is doing it? If you're doing it? Okay.
I mean, I would ask, I forgot your name from Blue Cross Blue Shield, but it is, I mean, because really the insurer is ultimately gonna save money down the road if it's a more proactive approach to healthcare. I'm curious, what, right?
I mean, I think that's applicable to a lot of different variables, right? So whether it's transportation, nutrition.
Right, all of the above.
There are a lot of
Yeah.
things that are further upstream that can reduce illness, morbidity, costs. And so I think as, both insurers, providers, employers kind of evaluate ways to help ensure that people are healthier and that their care is more affordable, that we look at these different opportunities.
And you've been doing a lot in the food area too, which is really impressive. Yes.
Yeah, and I would say that what's really happened and continues to happen is that arrangements between payers and providers are moving toward what's called value-based care.
More risk
So it's
is
really
shifting, yeah.
outcomes. So it creates for the providers a financial incentive
Right.
to go after some of these social determinants because the outcomes then are better and they don't care about it.
We hope. Yeah, I mean, that's why this report came out at a good time, was the move toward value-based. Yes.
So with your system and based here in the city, happen on the periphery of the city, because I know a lot of the systems actually have facilities all around, actually even probably touching on some of the areas that are right on the edges of the city. The transportation, does that work out there the same way, or is that primarily in the inner city area?
In the suburban world, it's even more complicated sometimes, because if there's a township bus, it won't go past the line of the township, right, Pat? You've had that experience. And so it's sometimes even trickier. But, if we really need to make this work, we need to think city-county. You're absolutely right, in order to really make it happen in the right way. You had a point over there.
No, I was just going to say, I work in the far southern suburbs, and recently there was a town hall between Metro and how do we come up with a collaboration, because it is very difficult. There are people that work and want to get to not only their jobs but to their appointments. If it takes 3 hours to get what's a 20-hour-minute drive, it's too much. And then they have to exchange from the Metro system to the pay system to the CTA.
Absolutely.
And so this forum was to allow the Metro, say, for the first time, that they're going to do a collaborative and partnership and really look at what that investment looks like, even if it's a single payment that exists between the systems. And I think that would benefit communities greatly and increase access.
Absolutely. Great point. Yes.
I was just going to say something along that same line, that if transportation is a barrier to healthcare, it's also a barrier to nutrition, your job, education, and it really does require a much more global approach than just, arranging transportation to appointments and to.
Absolutely.
Yeah, so,
Absolutely.
I think that's where that advocacy piece comes in, that, as a group, we need to advocate for working transportation systems so that people can access all of those.
Yeah, because in this world of being concerned about loneliness and isolation as a big factor in general in terms of well-being, but also has health outcomes, we now have new evidence. Just getting to somewhere where will be more meaningful may be just as significant as going and getting your blood pressure taken, Maurice?
Yeah, I was just going to say that I think overall it's very frustrating for providers, and this awareness issue to ask about it and then not feel like there are solutions or
Well-
what they can do. And I think refer to social work is a historical thing, but that's clearly not,
It's not historical enough.
That's an outmoded concept. So, but I think what's most exciting are these systems put in place, software and otherwise, that allow this to be integrated directly into the process of care at the time the provider sees the patient.
And we
So
did
both proprietary
review.
software and others, yeah.
I think the premise and the guiding light here was very strongly, don't screen unless you have something to give someone. And a lot of people are using now POW, Healthify, and Birth as those sorts of things, as curated resources with closed loop referrals. But it doesn't mean you don't need that human touch somewhere. Not everyone can do that on their own, or they've used those resources before and felt like they weren't helpful, or they felt dejected or rejected. So we have to be very careful about that too. So great points.
One thing that's actually complicating that picture a bit is the closure of safety net hospitals.
Absolutely.
Metro South is closing, other hospitals are now on the brink of closing, so that access becomes even more critical.
Absolutely.
So, people have to actually travel longer distances, break their relationships with providers who are local to them.
Yep.
So that's another issue that
Pat?
Are there any lessons to be learned from the VA? Because the VA provides free vouchers, transportation vouchers, and cards.
Has anyone studied it, Pat? Oh, yes, the person next to you.
I was exactly going to mention that. So I'm Nellie Vasquez-Roman from a Safe Haven Foundation. We've been working with the homeless population for 25 years. And the way we've made it work is, first of all, we've been funding this out of pocket, out of our operational budget. It's absolutely necessary that we connect people to all these different services we talked about. But specific to the VA, we've been contracted with the VA directly for over 10 years, working on the homeless initiative, and that contract does include transportation. So that has been extremely powerful as a link to allow us to help specifically transport veterans to the local VAs, hospitals. We can certainly use more funding to get them to job training and jobs and different things, but that's an example of how we were able to integrate a healthcare system with a community-based behavioral healthcare delivery model that, again, integrates the healthcare with community-based behavioral healthcare, and very powerful and should be a part of all contracts.
And the VA does give the homeless veterans, they get the Metro cards, they can ride anywhere.
And what you're saying, that is part of the future, hang in there. No, Pat, yours is, but what was your name?
Nellie.
Nellie. That's so. You'll see that a big part of how to get this done is connection with community-based organizations.
Yeah,
It's
a must.
It's a must, but the trick is how do you remember to help finance those places that have been very under-resourced.
Yeah.
So
In terms of these services, behavioral health services.
behavioral health, any.
We've been working, as we know, with the 1115 waiver and hoping that is part of that solution.
Yeah,
Make sure that
and that's
state funding, and also private health insurance is thinking more about the integration of institutional healthcare and community-based behavioral healthcare, and so those are two things.
I was just saying it was a big part of this discussion, and I'll get to a little of the struggles related too. So the key necessities for successful integration, as the consensus panel agreed, is an appropriately staffed and trained workforce, health information technology and innovations. Technology was a major discussion. We had the former ONC director, Karen DeSalvo, as part of the panel, so of course that came up a lot. And then a lot of financing discussions, people who had been at CMS before, so we had some big thinkers in the room trying to plow through some of these difficulty things. But all of these things we believe we're required to change in order to really make a difference. The first one around workforce was really about how do we figure out, there were great debates about, is there a social care workforce that already exists, and what do we call it, and what happens in different areas, and what's the importance of role clarity, and who does what. There was a study way back, not so far back, 2011 from Robert Wood Johnson that says kind of what you were alluding to, Maurice, that a lot of primary care physicians, I believe about 1,000 were screened, and they knew that 1 out of 4 of their patients needed more of a social referral than a physical one, and they didn't feel comfortable doing that for the reasons that you stated. They probably didn't have a social worker in there, Maurice. So we really, some of the issues that we talked about in terms of workforce is this part of the workforce, the social care part, doesn't get easily reimbursed at times. And how do we stand this up if we don't have that reimbursement? So, but the major discussion too, not only had to do about social care workers, and we included everybody and anybody in that, but really specified that social workers were trained in this and had expertise. But there are a lot of other groups, community health workers, nurses, you name it, we listed it, gerontologists. So that was the big workforce discussions and findings, not findings yet. And then we talked about technology, and we talked a lot about advances in technology, and they have the potential to integrate, particularly if you're integrating between healthcare and social care. This has not been done well in many settings, and there are lots of reasons for it. HIPAA, different sorts of laws, and cautionary discussions about what communication gets across. There was an example given last week of the unintended consequences of finding ways to communicate, where a young family was homeless. And somehow the fact that they were homeless, that information got communicated to someone, maybe it was a CBO, I don't know, but child welfare found out about it and took the kids away. So it's that kind of stuff. How do you, maybe, let's hope that was an extreme example, right? But, nonetheless, we have to be concerned about that extreme example. So that whole interoperability is something we spent a lot of time on, and whether or not we have a good enough infrastructure. And of course, the answer was no, and how do you encourage that infrastructure? And even if you do, like with NowPow for us, when we want to partner with our community-based organizations, if there's a cost to them, that just isn't going to work when most community-based organizations can barely keep the lights on. So how do we figure all this out, and how do we create that social safety net as we're talking about in modern times when there's so much technology, but how do we put it to good use in this area? Around financing, this was very tricky, and the legal definition of healthcare affects the inclusion of social care as part of the healthcare system. This is a really critical factor. Basically what it means, here's a couple examples. So social workers, who we know is part of, hopefully a big part of the social care workforce, they are really cannot be reimbursed for certain codes. Now, this is still in a fee-for-service world, granted, but sometimes we worry that the fee-for-service thinking, some of the thinking might travel to the value-based world. And in the fee-for-service world, they are not considered healthcare professionals. In the 80s, in an attempt to become mental health professionals, they somehow lost their status or being called healthcare professionals. So they're not eligible in many cases to drop codes for health and behavior interventions, behavioral health interventions, integrated behavioral health, not psychotherapy. They are, because of that, what that change did, but it took away some other things. We know care coordination is so complex in terms of getting reimbursed. Been working on that with some of you forever, right, Pat? And it's extremely tricky when you know those services are needed, and you know they're needed not just in a hospital, but that people live in the community and they don't live in our hospitals. And how do we make sure that they are being supported in the community so they don't have to come back unnecessarily to our hospitals, our emergency rooms? I mean, the transportation thing is when I finally thought about some of our Medicaid folks who come at night, and we broke it apart. Well, they were coming in the evening partially because they couldn't miss 3 hours of work, number one. Number two, The waits were longer when they came in the evening, but at least it didn't take away from their work. And also, just when people use 911 and take ambulances more often, it also has to do with finances. So, all of those things that happen. So the financing piece, there was great hope with the value-based world and structures that we would align incentives better for social care. So that's a watch and wait. We hope that will happen. I think it is happening in certain systems, so we applaud them. And some of those programs are listed and kind of in sidebars throughout the report. And financing was a tough one. So 5 goals for effective integration and select recommendations would be to design a healthcare delivery system to integrate social care into healthcare, build the workforce, design a digital infrastructure that's interoperable, finance the integration of healthcare and social care, and fund, conduct, and translate research and evaluation on the effectiveness and implementation of social care practices in healthcare settings. There was a great belief that there still is not enough evidence, even to the point where this group could not recommend universal screening. There was a big debate in the room over many, many months, but the outcome of the debate was, we don't know if it's best to screen everybody, to target certain folks to screen it all. There are lots of debates. And the researchers in the room, not to insult researchers, of course wanted more research in this area. I mean, we would kid with them and said, of course you have to keep your job going. Sure.
Robyn, it's Cheryl Arbiter. As a health systems and outcomes researcher, I have been struggling with this issue since I started, since we've known each other.
Yep.
It took 17 years to get research into practice. I believe it's down to 14 years right now. Is there any consideration to use Quality Improvement Plan, Do, Study Act to really mitigate this issue?
Well,
and to expedite how great practice is being done but not being recognized because it's not quote unquote evidence-based, but yet it's promising and
I agree.
practice.
And I think we do list some promising practices. We had Kedar Mate, who's now the new Don Berwick of IHI in many ways, on the committee. And he never pushed Plan, Do, Study Act, and that's their mantra. It was so interesting that he didn't push that, and actually agreed with most of the researchers that it needed to be more robust and intense. I, of course, agree with you, and can't imagine why it's taken so long. The Innovation Center, CMS Innovation Center, and I know some of you have worked at CMS, you can comment on that. We had hoped that it would be, further along and translate that more quickly than, I've heard 7 years, but you're hearing 14, or you've experienced 14. So on that note, I think there just needs to be a bigger push to get it to the real world more quickly. And we need more health service researchers that will look at social care. So that's the piece. So the recommendations are basically about how do you design healthcare delivery to integrate social care into healthcare. So how we do that, so much depends on each setting. So we go back to those 5 A's. We think everybody could analyze the system in which they work by assessing themselves to what those 5 A's are and where they are along that taxonomy to see how ready they are and how prepared they are to move forward. There is definitely in the report definite mechanisms and ways to move forward, but nobody wanted to ascribe to any one way as the right way. And I can agree with that because every system you're in, this as well or more than I, it has its own features and factors and culture and has to be attended to when you're thinking about rolling this out. So supporting the infrastructure of the components, establishing linkages, making sure that when you're bringing community-based organizations to the table, that you're just not assuming that they're going to pick up these pieces for no funding at all, but find some funding mechanism somehow. It could be, we talked about the community benefit that a not-for-profit hospital has. There are different mechanisms in which we can look at how do we think about this as a bundle, not to use that term technically like CMS, but how does the social care group, who may be doing more than the hospital is doing, get reimbursed for this kind of service in order to stay open and have their future solid. And then, of course, the whole building the workforce, trying to undo some of the very strange reimbursement policies that are related to certain social care professionals, such as social workers, and maybe begin to look at payments for things like, for people like community health workers, which everybody seems to be using more and more. So challenging the state legislatures, licensing boards, you name it. And we also spent some time on training that it's absolutely critical in all of education, medical, nursing, social work, whatever, to attend to social determinants. And one of the nods in this report is come utilize social workers to do some of this training with the other disciplines. Kind of unusual, but important, because if they are the experts, how important it would be for them talking to the other disciplines. Now, nobody is saying everybody needs to be a social care provider in this report. Nobody's saying it. They're saying, know what you know, probably just around the awareness piece, and then let other people on your team do the other part of the work that's necessary to provide the health for all. So, hope that made sense. And the digital piece, not only building internal capacity,